Good morning, all of you out there. I'm so glad to see your shining faces. I'm glad you came. We're going to talk about pearls today, and not just the pearls around my neck. We're going to talk about the National Academy of Medicine pearls. We do not have any disclosures, and you're emergency physicians, so you like stories, don't you? So I'm going to tell you a story. So once upon a time, a group of incredibly talented clinicians from all over the United States sat down at this table you see up there and talked about real important issues: patient safety, quality of care, and physician well-being. They knew, though, that one half of all of the providers, just physicians in the ED, are either burned out, morally distressed, or getting ready to quit. So they put their heads together and constructed a model. Some of you may know this. Over 20 years ago, this group, initially known as the Institute of Medicine, called for very dramatic attention to things like patient safety, quality of care, and this led to very major changes in the design of the healthcare system. Some of you remember the title. It was called To Err is Human. Anybody remember that one? So let's go fast forward 20 years, pretty much about 3 years ago, it was 20 years ago, and the Institute of Medicine changed its name. It's now the National Academy of Medicine, and it continues the work that it started two decades ago. Over the past couple of years, it's been working on a special initiative called the Action Collaborative on Clinician Wellbeing and Resilience, and that project has spanned approximately 3 years. And this group looked very, very closely at burnout and clinician well-being, and guess what they found? Initial research seemed to indicate that you, the individual clinician, could determine your own wellness, okay? You go ahead and you work out, you yoga, you do meditation, you watch your finances, you be social, and follow the spokes of the wellness wheel, and you will be well. But guess what? Research shows that this is not the case at all. You cannot yoga your way into wellness, and you cannot meditate your way into wellness. So this is where the National Academy of Medicine conceptual model for clinician resilience and wellness comes into play. Remember that round table of clinicians that you had up there? Those smart people made this model. This model is worth looking at. You see patient well-being in the middle. It's surrounded by clinician well-being. Those two depend on each other. And you can see all the factors surrounding those are the factors that determine your wellness. So 2 of the factors are blue, and those are the individual factors. The other 5 are determined by the system. They're system factors. So clearly and unmistakably, the system factors contribute most to our well-being. So changes have to happen at the departmental or the institutional level to impact us at the individual level. So this model, though, led to this report that the National Academy of Medicine put together, and it's called Taking Action Against Clinician Burnout. Can you believe that? Well, I can believe it. The National Academy of Medicine actually established clinician well-being as a national priority. That's real important. So they also went ahead and developed this perspective paper that showed organizational evidence practices for improving clinician well-being. So what did we do? Well, we took all of those pearls and put them in our hand for you. There are 5 that are really important, and we're going to go through each of those. Positive work environments, positive learning environments, reducing that admin burden that we all hate, providing support to clinicians and learners, and investing in research. So let's go with the first one. Okay, I like examples. So, New York Presbyterian in New York City has about 50 board-certified emergency physicians, and they established a committee for physician satisfaction and wellness, where listen to this. The mantra is provider satisfaction is just as important as patient satisfaction. Pretty radical, huh? And one specific example comes to mind, and that is during their shifts, emergency physicians get breaks, 20 to 30 minutes. They actually have to leave the department. If you're working in the academic part of the system, the other attending will cover for you. If you're working in the community side of the system, then you don't get assigned any patients until you came back. And in a survey after the change, they found that emergency physicians reported increased productivity after the break.
So we definitely know this works because I've talked to physicians in New York. They're out eating at a deli. So how could we make this work at your own institution? Like, it's for sure legitimate that they support it, and they're out there relaxing for 20 to 30 minutes.
Yeah, Dr. Connor was telling me didn't you text somebody?
Oh, I was having a full-on conversation while I was sitting outside, and I asked him, well, who's covering your department or your part of the ED? And he said, well, there's a senior resident, and we support having our clinicians eat lunch. So
pretty amazing.
How would it work in your own institution?
Yeah.
Did this have any impact on the people who were covering the shifts, like that senior resident?
They all quit. No, I'm only kidding. I'm kidding. I'm kidding.
I think it extends to every member of their department. So if you're eating lunch, then someone else is not, and then they can go and take a break.
In the stuff that I've read, they have, there are some people that don't take breaks. We won't go there. So anyways, how other ways can you create positive work environments? Well, eliminate those early morning and late afternoon meetings so that people that have kids can provide can provide pickup or drop off. And the other thing that happened, especially during COVID, was verbal orders and the CMS waiver. This really reduced the burden of computerized order entry on physicians and APPs and allowed nurses and other people to put in orders, which is pretty good. And then collegial dinners. I don't know how I feel about these, okay? These are funded meals to groups of colleagues to sort of talk about their experiences and bond, and I think it's good. What they found, though, that it really did reduce burnout and increase meaning of work when they compared the group that had the collegial dinners to a cohort that didn't. So.
Great, so I'm going to talk a little bit about the strategies of trying to improve sort of positive working environments and positive learning environments. So right before the pandemic, I taught a course with service designers and ritual designers looking at human-centered design to improve well-being in the emergency department. And if you look at this sort of schematic, this is a service designer looking at our day. And I mean, this is specific to Stanford where I work, but it's probably very similar to what you see. So what he wanted to map out was, in a typical day, where are areas where you can spark meaning in your overall workday? So taking the routines that you normally do, be they handoff or cleaning your workspace before you sit down, and sparking some sort of meaning to bring it out of the sort of mundane. And service designers work at looking at the processes that are a service and improving that both for the user, which is your patient, and you, the provider. So I can advance myself. So this was taught in the design school, and we sort of challenged these students to be like, okay, well, what part of, and none of them were medical students except for one, what part of your day would really bring some sort of well-being and wellness to your emergency shift? And so what they thought of is, we have a lot of off-service residents that rotate through our emergency department, and they tend to feel very, very uncomfortable because they're there for maybe 2 weeks or a month, and then they come back 2 or 3 years later. And so what they thought of doing was giving each intern that rotates through our emergency department a little chime. So these are not, remember, these are not medical students, and writing down what values brought you to the emergency department, make you excited about, for me, pediatric emergency medicine, and then hanging it. This doesn't work if you don't like sound, but you could do, pictures, whatever it is that reminds you of why you wanted to come to the emergency department. And so they had this idea that you would chime in, chime out as a way of sort of like centering on those values. And so I can show you this little video if it will work. Let's see.
You got to click it again.
different rituals that they were thinking of sort of looked at sort of pain points, and one of them was looking at asking questions in the emergency department. And this one actually came from the one medical person in the room. And what he thought of was that lots of questions come up during a shift, be it that you're the medical student or the resident or the UA or a nurse on the team, and you may not feel comfortable asking, well, why is it that we do this? And so he thought of like handing out these Post-it notes and creating a board where you would have questions for everyone and questions for the doc. And then maybe the senior resident or an attending would sort of stop everyone and have what he called an ED blitz. And you'd pull off all these questions, and if there were questions for the doc, then the doc would answer, and if there were questions for everyone, anyone would have a chance to answering, and they would all be anonymous. And so it would be a time to bring everyone together to answer things that maybe people are like, I don't understand why we have a 2-visitor policy, or things that come up all the time, but you feel sort of uncomfortable asking. And then you'd have this sort of bonding moment to discuss why we do things the way we do in the emergency department, and then sort of start all over again. I think I have 2 more here. So the last 2, I believe, we're really looking at how we do handoff and sort of the anxiety you have of leaving a messy board and trying to sort of celebrate the hard work that you've done during your shift. And so again, they wanted to sort of mark these moments that, okay, you've worked really hard on your shift. How do we like celebrate or mark that this is the end, instead of this kind of straggly end to most of your shifts where you're kind of running around trying to pick up the loose pieces so that you don't leave them behind, but really be like, hey, you worked really hard. How do we like collectively sort of congratulate you for finishing your work, and then sort of mark it and herald it as you leave. I think one more here. And the same sort of for handoff, that they actually had this idea that what if the EHR could give you appreciation messages? And that's the whole point of human-centered design, right? So I know you're like skeptical, we can't do that with Epic, but maybe we can, and that's the whole point of design, to really think broadly. So it would, in addition to being like, okay, patient A has this pending, but let me look at all these appreciation messages that came from maybe your UA for communicating well, or your patient for circling back and updating them, and then having some sort of code phrase to hand off the board. That's it for me.
So Dr. Manfredi forgot to have everyone introduce themselves. She was so enamored with her pearls that we forgot to say who we were. So, hi, I'm Dr. Rita Manfredi from George Washington University in Washington, D.C.
I'm Kajal Khanna from Stanford University in pediatric emergency medicine.
My name's Mark Courtney. I'm from UT Southwestern in Dallas.
So now we're all friends, okay? So we are going to go and do more pearls, and this is the second pearl. How do you create a positive learning environment in your, in your emergency department, in your organization? Well, the way to do that depends sort of on the leaders. The leaders have to know what your unique talents are so that they can know what motivates you. Have any of you heard of the 80-20 rule? Okay, yeah, I know Sadia has. Okay, so let's talk about the 80-20 rule. The 80-20 rule, evidence shows that physicians that do and participate in what gives them most passion, most professional fulfillment, are at much decreased risk for burnout. So that means that the other 80% of the time, you are doing what your leadership, your organization wants you to do. And for us, that would mean, either we're doing something admin or working clinically. But the way this principle works is your leader, your chair, the head of your organization needs to know what your passions are so that you can facilitate a really robust way to develop them professionally.
So this is kind of a little bit of a similar point, or kind of another just kind of conceptual model to think of that through. My role right now is as Executive Vice Chair of Academic Affairs. So what really I'm interested in for my faculty is when they're not working clinically, what are they doing and why? And where's that coming from and where's that going? And sometimes that works out really well and sometimes not. And most of the time over my career, when I have either struggled myself with unhappiness or participated in conversations with others who are dealing with unhappiness or unfulfillment or burnout, it's often because there's a mismatch between what they think is important and what maybe the department thinks is important. So in an ideal world, I mean, you've got this kind of Venn diagram, and you're trying to find that sweet spot right there where it all comes together. You can never really be all the time in that sweet spot, but that's kind of the ideal in a way to kind of think that through. But a lot of times this is kind of what you end up with. You know, I mean, everything is kind of, you know, mismatched, lumped in different ways, and you've got a little bit of overlap with your goals. You know, you've got a little bit of overlap with the department goals. We have no idea what the institution really cares about. You know, you just kind of trust your chair is going to tell you what to do or something like that. And that's not really an ideal situation. So trying to kind of reframe this is a lot of kind of what my conversations are. I think it can be helped with an instrument too. At our institution, we've got a form that we ask all new faculty to fill out. I'm actually now kind of asking all junior faculty to fill it out too. I hate filling out forms. I have FOFOF, which is fear of filling out forms. I almost didn't get my Texas license because when I moved there, I could not fill out forms. Literally, cannot do it. But you know, this form it's on the cloud. It is a living document. It's essentially a Microsoft Word cloud document where we're asking faculty to provide a vision, provide a mission. What is, if they're successful professionally, how does the world look different 10 years from now, 20 years from now? What are they adding value to? It's a little bit audacious and a little bit kind of visionary. And then we kind of can subdivide that into some intermittent goals, and it changes over time. So I meet with them, and usually it's like, I want to get a grant. Oh, okay. But that's the beginning, and then we kind of work on that a little bit further. So that's really kind of, you know, ideally finding a way to communicate here and find a little bit more ways to get this alignment. But it really comes with communication. If any of you guys want a copy of this form, I can let you know. I can provide that to you. Again, I'm at UT Southwestern, and my email's available through the app, or you can just email me at any time. And it came from stuff that I think has been done at other institutions that my chair put together, and now I'm kind of beta testing.
Mark, I have a question for you.
Sure.
I don't need that. You can have that. Do people know to change that document as the time goes on? Like, say they've been there 10 years. Like, some of you may have been at your institution for 10 years. And who routinely looks at those?
Yeah, so we're still beta testing and rolling it out. The dean has required all new hires to have this, interestingly. It can be different in different departments. As it is, it's kind of me. I think we have a big department. We've got division chiefs. I'm going to offload some of that to the division chiefs as I get a little bit more experience with that. But they're the ones that are a little bit more kind of, for some faculty in EMS or toxicology, ultrasound, sim, that may be. So still going to work on it. I think probably every year you have to take a look at this, dust it off. We have faculty evaluation forms that are every year, but this is, you fill it out, it goes away, nobody ever looks at it again. This is designed to be a living document. I like that it's on the cloud because we're all looking at the same thing. They can edit it, I can suggest comments, kind of fine tune this a little bit, and then it's really useful when you're trying to figure out what to say yes to and what to say no to. No, this is not a high priority on my individual strategic plan. Then we're going to take a pass on that.
Yeah, and I'd like to say that that's just a really good system change that can really impact you individually. And we're going to have time at the end because I know there's some people from Sinai in here who have done really good things that I'm sure you'd like to share with everybody. But anyways, let's move on to our third pearl, and that is reducing admin burden, which we all can relate to, and enabling technology solutions. So tell me how many minutes of each hour you spend with patients in the ED. What do you think the average time is? Just yell it out. 5 minutes? Who else? 7. Of the whole hour? That's all you spend with patients? What about you, Keith? 20? Yeah. Andrew? 15. Yeah, you're just listening. Yeah. So, yeah. Well, the number's 19 minutes. Just think about this. Would our founding fathers of medicine really want to hear that we're doing that? I mean, it's amazing. So, so what can we do? So let's go back to Cornell Weill. Okay, I like examples. They hired scribes. This was a little bit before COVID. And they track down the ancillary data and the test results. The nurses print out the work notes. The admin clerks put in all the information for prescriptions. But the big push at this hospital is to decrease the clerical burden of the emergency physician so that they can take care of patients and not be data entry clerks. Because isn't what we're doing now a lot of data entry? We didn't used to have to do this if you're old enough. Anyways, we're going to move on to enabling technology solutions, and Dr. Kodges are going to tell you a little bit about that.
Yeah, so I'm going to focus a little bit on human-centered design because that's one of the pearls that was sort of brought up as a technique. And how many of you are sort of familiar with design thinking? I mean, I think we've all heard about it. It's like another catchphrase. It sounds sort of like a PDSA. Well, what's the difference in using this as a quality improvement tool, using your other sort of models? And so the real difference here is you want to empathize with the people that you're trying to create the new process for. So when you look at design thinking, and there are a whole bunch of different models out there. This one's from Stanford, but there's Plattner in Germany also has one. IDEO has one. So you start really by interviewing and empathizing. You want to gain a different viewpoint, right? So if your faculty members are having some pain point somewhere that you're not seeing, so you're going out there gathering information and kind of really changing how you view the process. And you want to test your assumptions, like, hey, I think everyone's spending 25 minutes with a patient, but maybe they're spending 5. So why is that happening? And you want to look for inconsistencies so that when you bring together your model, you bring together your solution, it's something that, okay, I'm going to tackle this point, which may not be similar from a junior faculty perspective to a senior faculty perspective. Then you want to define your problem and sort of synthesize all of this information. And then you're going to ideate and brainstorm. Like, the sky's the limit. So these students that were like, I'm going to put appreciation messages in my EHR. Like, those ideas do need to be considered, even though they seem really, really far-fetched. And you want to think of, like, okay, how do we do X? But not just sort of this blanket statement, but like, how would we do X with $100,000? How would we do X with $1 million? So really kind of tackling your problem with different set of constraints, so you're not just shooting out this idea that doesn't have any sort of constraints when you try to apply it. And then you're going to pick, let's say, 4 of the ideas that you brainstormed. So maybe pick the one that would be the darling for the department, that would be the delight for the department, that's like the long shot, and then the rational idea. And you're going to prototype them. So you develop these lo-fi prototypes, like the video where they use the wrench for a chime, and see how your users like it. And then you assess to see if the model worked, and you go back and sort of use this whole design thinking process again. So really trying to bring sort of this empathy, and then the sky's the limit to how you design a different intervention for what's not working in your department. And then this pulls sort of system-centered design and human-centered design together. So if you look at sort of, it's kind of a little bit like a SWOT analysis, right? So insights, opportunities, solutions, and data are layered onto sort of the idea that we were just thinking about, where you're interviewing, empathizing, prototyping, and testing. So bringing those two things together, because you're probably pretty familiar with systems design thinking, because that's what you all have been working in, a system that's very multi-layered, and layering that with human-centered design. And I think this is my sort of last sort of technological, to bring it all together. The AMA has this new guideline, sort of gross, getting rid of stupid stuff and really trying to reduce the unnecessarily daily burdens for clinicians. I think also looking at like the tone. So there's a great op-ed that's really old, but when what used to be San Francisco General went to Epic in 2019, so very late to the Epic, they were all super excited, and there's a really beautiful article written by, I think she's internal medicine, talking about how when she first logged into Epic, she'd never used it. She got sort of struck by this the familiar yellow sign, well, for me, familiar, saying that she had unsigned orders, even though she'd never even signed into Epic. And so she was like, well, what's the tone of the EHR here? It's like making me feel embarrassed that I didn't do something, even though she had never even been in the system before. So really looking at what is an unnecessarily daily burden. You don't need to be slapped with this yellow sign that says you are delinquent, even though you may have worked really hard overnight. So changing how we do sort of basic technological solutions might be an easy fix.
Yeah. And in this, just go back one, Just what they did here also, one system, you know how you get those EHR alerts that just bug you? Actually, they got rid of like 10 of them. All right, 10 is better than 0, right? But that's how they got rid of stupid stuff. And the other thing I wanted to point out that Dr. Kano was telling us about was that, medicine is so far behind what other corporations are doing. I see everybody shaking their heads. I mean, Facebook, Google, they are eons ahead of us. Just in medicine, we have not translated those practices from business into medicine, and that's what we need to do, But another way to decrease that admin burden is reduce the inbox volume or ignore it.
Well, sure. So, you got to do your charts. You got to get your charts done. You got to that's pretty high on the institutional priorities Venn diagram there, right? Is getting your charts done and signing your charts. I'm going to talk just a little bit about something that's a little tangential, that's a little bit more inbox of your email, right?
Yeah.
A lot of times people have a lot of anxiety over unanswered emails. And a lot of times, I've found I am at my least productive when I am using my email as my task list or my to-do list. I show up, I got an off day, I'm in my office and I'm trying to get some things done, and I open up my email and it's like tons and tons and tons and tons of emails. And, the harder I work to answer my emails, the actual perverse thing that happens is I get more emails, because then everybody knows I'm a pretty prompt responder, and the emails that I sent in the morning, now people are responding to in the afternoon, and I got to respond to those. So there's a lot of thoughts on inbox zero, how do you do that, and there's a lot of productivity things and time management stuff. A fantastic book I read by this guy Oliver Burkeman really kind of challenges all of that and asks the question of why bother? Let me ask you guys a question. How many weeks do you think there are in the average human lifespan? Give me a number. Take a moment. Think 0 to 80 maybe. This is kind of the amount of weeks you have on this planet. Maybe you live a little bit longer, maybe not. Take a guess. What numbers do we have?
50 times. You mean 50 weeks? 50 weeks a
80,
year.
no.
50 times
80 years old. We're gonna
8
say.
years old.
We're gonna assume that. No.
50
We're gonna assume that you're gonna live to be 80
80.
years old. Okay.
That's 4,000 weeks.
Yeah, it is 4,000 weeks, right? So this guy Oliver Burkeman wrote this book called 4,000 Weeks: Time Management for Mortals, where he basically just says, forget about your inbox. Try to concentrate on focusing on the things that really, really matter to you. Figure out what your values and priorities are, and spend time working on those things. I think the career development, forum that we were talking about helps give that a little bit. So that's kind of my experience. When I left Northwestern, I had tons and tons of emails. I had 8,000 emails, and I was trying to archive them because I thought they were going to be really important, and I ran out of time. I had to move. I had to sell a house, had to buy a house. My daughter was there trying to try out for cross country, living with my chair, which is a whole nother hilarious story. And I never did it. I never was able to archive any of my emails, right? And guess how many times I have really felt bad or needed or wanted those old emails? 0. Never. Not once. And if I remember something hey, that geriatric project, Scott Dresden, that we were working on back when I was at Northwestern, could you give me that protocol? I just call them up. And now I'm forming a human-human interaction. And that's where I find there to be a lot of meaning, because Rita and I have a little bit of a different philosophy. My philosophy is that you can find a lot of happiness internally, and yeah, it's not yoga and it's not these kind of kitschy things, but yeah, the way your brain functions and what you do with your brain and your thoughts, there's a lot of science behind that, and forming communications with human beings is really what it starts with.
One of the chief wellness officers up at the University of Massachusetts, while I was corresponding with him, was away on vacation. So I got this, you know how you may put these automatic things in, I'll catch up with you when I get back? His didn't say that. His said, this is amazing, and I sent it to a bunch of people on the wellness committee. His said, I'm away on vacation, I'm trying to get, I'm working on my wellness, and I regret to tell you that I'm not going to answer your email when I get back, because I will have a ton of emails and I won't be able to deal with that. So if what you're emailing me about is that important, please send your email again. And I said, wow, that's pretty cool. It's a little annoying, but it was pretty cool. So, well, no, I was just, yeah.
It's putting the burden back on the sender to say,
Yeah.
This is important enough that I'm going to send it again a week from now. And And if it's not, it's not.
But
That's
it,
okay.
right, but I agree, though. I still think it was great that he did that. I'm thinking, you are walking the walk, you know? Here we are, we're all struggling. Yeah, go ahead, Sonny. Oh, we're supposed to give you the. Sorry, Cheryl, we didn't get you.
No, I was just going to say, like, I know this is like a huge paradigm shift, but there are institutions that are thinking of like telling everyone not to send emails after a certain time frame in the day, like no emails after 7
5
p.m.
p.m., yeah.
Or because unless it's urgent. And I think that it goes back to what you're saying. Yes, you need to find your inner peace and figure out, okay, how you can survive in that crazy world that we live in at work. But there's got to be like system change to allow those kind of efforts to take place. So I just feel like, I want to commend you for what you're saying about the emails, but I think if the department decides that, you know what, we're in emergency medicine, we work all odd day and night hours, but the rest of the hospital doesn't, and so, it's okay if I don't get back to this person until like 9 o'clock the next morning, because that's what their business hours are like. So I think just to put a plug out there.
No, that's true.
Good morning, Cheryl here on Emory. Thank you, Saudi. I think that's so true at Emory. Literally, there was this anxiety about shutting down the week between Christmas and New Year's. And the university said, we're shutting down, we're not doing anything, and that's that. So it came from above, and we got like no emails. It was fabulous. And people spent their holidays, and if they needed something, they called you on the phone, and it just created a whole different culture from above that says we're not doing this in this week, so everyone can have this week to do whatever you want to do, and it actually worked, right? So we can, work within the cultures we have and support that. Thanks.
Just a comment. I love the idea of the school receiving a little email telling them that I'm not going to be reading the little blurb newsletter that they're sending me. Because it's true anyhow, I delete them straight off. But I love that bounce back idea.
Yeah.
Yeah, I think it has a name called auto archiving. I think that's, if you look that up, you can get some sample text to use.
Yeah,
So
I
that-
would say even so, in France, they went even as far to say it's illegal, right? So after business hours, you cannot log in and you cannot send. So, okay, so it's not France, I get it, different work culture, but something as similar as that. So it's twofold. One, you shouldn't have the anxiety to check, right? Because, oh my God, I might miss something. I went to the Galapagos with a bunch of doctors, and we had no service. And then we landed somewhere, and everybody was frantically like, oh my God, I must check, right? Was there anything important? No. So pick up the phone if you really need to, make your human connection. But
Yeah,
I think if we were to
absolutely.
move so far as say, you can't send them.
Well, and
then
save
what?
for the Galapagos.
Exactly.
Yeah, that's right.
And
That's
what
right.
you should be doing.
And although this sounds like so advanced to us and so innovative, there are thousands of organizations out there that do that. CHG, no emails after 5 p.m. That's it. Why are we so slow? Anyways, we'll just go through the last couple of pearls. We have to provide support to clinicians and learners. There are buddy systems that occur. There's a buddy program at Cornell Anesthesia where the big point here is that they pair people in the department with people that are new, right out of residency, as well as those people that are experienced. So it doesn't matter how many years you have.
Yeah, so there's a lot of peer-peer mentoring, peer-peer buddy system, support system, faculty development. Every department kind of has its own little flavor. I have found that none of them work great. A lot of times it requires effort and time on the part of everybody. I want to talk a little bit about something that's different, and that's coaching. And coaching is a formal thing that is really kind of exploding in medicine right now. When I got to UT Southwestern, it was the perception that somebody was not performing well. Maybe they had had some communication problems. Maybe they had had some conflict with a consultant. They had, we have this thing called safety posting, which is where, if somebody, it's supposed to be to identify errors or problems or harms or potential risks, but it's kind of become like, oh, I didn't really like the way the hospitalist talked to me, and boom, I'm going to safety post that person, right? And it's kind of a little bit of a mess. And so if you get referred to the professional committee, or if there's significant problems, then sometimes you might be assigned to go to coaching. That's really not ideal at all. Like, that's not the way coaching is supposed to be. Coaching ideally is a one-on-one formal process whereby a trained coach interacts with a client to try to help get them from where they are to where they want to be, to try to get them from where they are to who they want to be. So it's really a lot about kind of how can you help and facilitate people in some self-driven process of transformation. Now, sometimes that can be done because they really need help and they're really struggling for some reasons that are really problematic. But coaching is now kind of taking off at a lot of places. We're going to look at a little bit of data because we're kind of at the last pearl that has to do with research and what wellness should be doing as far as research. And coaching is one of the things where there's actually a little bit of science and research going on. So coaching is not focused on problem solving. It's focused on person growth and transformation. It's not really the coach telling the person what to do, like a basketball coach saying, go do some drills. It's listening. It's really active listening. It's looking and using your insight to try to find ways in which the client can self-discover new ways of going about things. It's not therapy. It's not fixing people who are broken. It starts from the premise that people are naturally creative, whole, and resourceful, and able to solve some of their own problems when given support. And it does have to come from a place of training or expertise. Our institution said, we got bad engagement scores, we got some unhappiness, we got some burnout, we got some unwell-being, and they basically were sold to develop a culture of coaching. So, hey, they hired somebody to come in, they got all the existing coaches that were at UT Southwestern together, they recruited 20 faculty, including myself, to participate in a coach development program, which is a whole year. You got to coach a whole bunch of people. You have to get observed as a coach. Eventually, you can get signed off and get certified as a professional coach. And they're trying to develop this culture of coaching. We're going to dig into that a little bit more. It's not therapy, even though it can be therapeutic. So this is a definition from International Coaching Federation. If there's one website you wanted to go to that's kind of not BS and is actually pretty highest quality kind of coaching info, it would be this, the International Coaching Federation. Partnering with clients in a thought-provoking, creative process that inspires them to maximize their personal and professional potential. Often unlocks previously untapped sources of imagination, productivity, and leadership. So most of the value of coaching is not really the presence of a coach, it's what happens in between. So you might meet with a client once every 2 weeks or once every 4 weeks, and then there's a whole lot of other stuff that's going on, in between, that the client is living life and bringing those experiences back to the table in a coaching session. So is there science, additional science that we should discuss and talk about as it relates to burnout and wellness? When you're wondering kind of where the science is, take a look at clinicaltrials.gov. And, Steve Bird was initially somebody that we wanted to be on this panel, and he couldn't make it because he's, I think, going somewhere and doing he was here at the conference, but then he couldn't be here on Friday because he's doing some talk on a trial that he has on sleep, I believe, as a intervention to reduce burnout among clinicians. So he's a big fan of saying, the time is done for just scope of the problem research. We need interventions on burnout, we need interventions on wellness, and we need to study things that work, not just describe how bad it is. So if you look at clinicaltrials.gov, there's 20 studies here, on coaching, just on coaching as it relates to, well-being. Now, I've scrolled through a bunch of these. Some of them are done and never published. Some of them have been published. Some of them are enrolling and kind of in the works. But this is work that's going on. This is one particular study. This was Tate Shannenfeld, who's kind of the guru of well-being and was at Mayo and is now at Stanford, but some other important authors that have done additional work. So if you wanted to just look up one kind of article to get you started and look at some author names, this is a great one to start with. These were family medicine, internal medicine, I think a few pediatricians, not a ton, but they randomized them to coaching versus non-coaching and found that, lo and behold, they experienced reduced burnout. And remember what burnout is. It's traditionally been this Maslow burnout inventory that measures depersonalization and emotional exhaustion. And so they focused mainly on that, and sure, they found that those values were reduced. There was some increase in well-being, and then interestingly, there was some other things like job satisfaction or engagement that were not actually changed by coaching. Steve Bird is at University of Massachusetts. He's the Chief Experience Officer there, which is kind of like Chief Wellness Officer, but they don't want to call it that, I guess. I don't know. So he's got a budget, which is not trivial, to basically do wellness initiatives for the entire health system. Not just doctors, not just emergency doctors, but nurses, PAs, everybody, nurse practitioners. So he's got a lot of a big task ahead, but I've never seen him happier. He was on the SAEM board with me, and so this is how, kind of we started thinking and talking about a lot of this stuff. So he is doing a randomized controlled trial that is wrapping up. It's not published. 6 coaches. They had volunteer residents, fellows, faculty, and APPs, 3-month contract, and basically people would have a meeting about an hour with a coach, one-on-one, confidential, and study well-being index, which is a little bit shorter and maybe a little bit better than the Maslow burnout inventory at 6 months. And so that is, going to be published. Now, I called Steve and I asked him about it, and he was really frank about what he's learned from it. One was that there wasn't as much buy-in as he would have hoped. And he thinks maybe that was because there were volunteers. Maybe if he had charged $250, people would be a little bit more bought in, and maybe they would have, been needing coaching a little bit more or invested in it themselves a little bit more. Because remember, you got to want to be coached for it to work. So the free aspect, maybe a little bit of some challenges. And then there's a fair amount of gender preference as well, sex preference as well, because it's, he found that there was a lot of women preferred to be coached by a fellow woman and not a male. So you need, recognizing that and having that balance is maybe an ideal for the future. Desire for confidentiality is not surprising. And then there's a little bit of challenges in being coached by someone in your department, because maybe you report to them. So I'm becoming a coach. I'm not sure how effective I'm going to be able to coach emergency medicine people that I also have to fill out their annual evals on. It brings up some interesting kind of challenges. So that is all that I have on that topic.
Just the clicker. And so we just, the coaching is much more formalized. Peer-to-peer support is less formalized, and it mitigates the effects of emotional stressors through empathetic listening. And we need to do this when we have these adverse events, like you have them in the ED all the time. It could be a difficult case, difficult patients, a severe death. It can be a death of your own colleague, something like that. But research shows that with peer-to-peer support, people want to talk to another doctor in their own specialty, no notes taken, no documentation, and they just want someone to sit there, listen to them, and be able to talk about what's bothering them. So our last pearl is investing in research, and this is research regarding wellness, and that is, if you can't measure it, then you can't improve it. So I want to tell you this example about answering emails. University of Virginia School of Nursing found that employees during their time off felt really encumbered by answering emails. So they did a pilot study, very small number of nurses. They stopped sending emails during their time off. Well, let me tell you, the benefits were immediately evident. They stopped sending the emails. People were ecstatic. They then extended it to the whole school. They measured it afterward, and they found 80% of the respondents said, wow, you guys are really respecting my personal time. So you can see those changes at the system level really impact you at the individual level. So I just want to tell you about this because I want you to take just 2 seconds to figure out where your institution is. So when organizations make changes in wellness, they go from novice on the bottom all the way over to expert. And as they get more experienced in what they're doing, their impact goes from minor to transformative. So I'd like you to figure out how your organization measures up. And so I'm going to tell you where most of you are. This one, novice. Many organizations are definitely aware of the issues of burnout and lack of physician well-being, and guess what? Most of them are in individual interventions. Here's this mindfulness app, or here, we'll give you some nutrition resources and the requisite ice cream social for our residents, or wellness books for the attendings, right? That's novice, and unfortunately, that's where many of us are. There are some beginner level organizations that have a better understanding of the drivers of burnout, which go from the negative side, burnout, all the way to the positive side of physician engagement. And that's where they start doing peer support. They survey their physicians, and they actually start considering well-being as when they're figuring out operational decisions. But it's not until the competent level that the organization puts its money where its mouth is. And that's where they do redesign. And they redesign based on those drivers of burnout and physician engagement. And they regularly, yearly measure a burnout. At the proficient level, they're almost there. They align their key objectives with physician well-being. There's no doubt about it. They have funded programs for well-being initiatives. They train leaders in participatory management, so they're starting at the top. And they consider well-being in all operational decisions. And this is my favorite. They actually use an annual CEO performance scorecard to measure senior management. We get evaluated every year. There are not very many organizations out there where you evaluate your leaders. And finally, at the expert level, well-being takes a very central role in the organization. They appoint chief wellness officers, although we're not really sure what their impact is right now. The expert organizations actually endow wellness programs that actually create opportunities for other organizations. And then there's this culture of wellness that trickles down all the way from the C-suite to us in the work unit level. So to close, I need to tell you about Southwest Airlines. So if any of you are flying out of here on Southwest Airlines, the CEO insists that employees should come first and that the customer isn't always right. So because of that, because they're empowered and they know their boss has their back, they really do innovative things. They treat their customers well. What happens if you have satisfied customers? You have repeat customers, and that's why Southwest is such a successful airline. I challenge you, take that model and translate it over to doctors. Doctors come first. And if their organization treats them well, they're going to provide exceptional care to their patients, right? And with that comes just a real sense of fulfillment. So that's what I think we have to do. So let's take that Southwest Airlines model and try and translate it into emergency medicine. And you know what? I think if everyone tries, we can do it. So I'd like to thank you so much for your attention. Here's our information. We're up here. Time is out, but we're up here if you have any questions or comments. Thanks.